Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comms. I'm joined by my co-host, Narayanan, infectious disease pharmacist and clinical associate professor at Rutgers University, New Jersey, USA, and fellow editor at CMI Comms.
Hi, Angela. It's great to be here with you again, as always.
Today, we are tackling tuberculosis. We are thrilled to have two expert guests with us. Lorenzo Guglielmetti works for Médecins Sans Frontières, Doctors Without Borders, where he is director of the endTB project. He is also a clinical infectious disease physician at the Hôpital de la Pitié-Salpêtrière in Paris and a researcher at the Sorbonne University.
Hello, Nava. Hello, Angela. It's really a pleasure to be here today.
And our second guest is Olha Konstantynovska. She is an associate professor in the Department of Infectious Diseases and Clinical Immunology at the VN Kharkiv National University in Kharkiv, Ukraine, where she practices as an infectious diseases clinician.
Nice to be here, and thank you very much for the invitation.
Olha, we're grateful that you're finding time to do this interview from Kharkiv, which continues to be under attack. As our listeners know, we start these episodes with a get-to-know-you question for our guests and also our hosts. Today, I'm going to ask, what is an important moment from 2024 that comes back to you again and again? My great memory from 2024 is a trip I took all the way to Wellington, New Zealand. I was very honored to be able to go to the Australasian Infectious Disease Society's annual meeting. And I have to say, I've met people there that I would not have met otherwise, including bringing Josh Davis on board as an editor at CMI Comms. Had I not gone to that conference, we wouldn't have Josh, who, by the way, is the person responsible for these icebreaker questions. So anyway, that was a really important moment for me in 2024. Nav?
I actually went back to India with my family for the first time in many years. My wife does classical Indian dancing, and so this was the first opportunity she had to go perform in India. We brought our two daughters. That was probably my best memory in 2024, as well as for a long time, and it was a pretty amazing way to start off the new year as well. Lorenzo.
My fondest memories mixes a little bit professional and personal. It's the end of this endTB project with the presentation of the second trial and the last part of the study, which happened in the Union Conference in Indonesia. It was an opportunity also to travel with a big part of my team from France and to meet many of the investigators from the countries which implemented the study. We rented a big flat. We went hiking on the volcano, seeing manta rays, and it was a bittersweet moment, but also the best way to close this adventure.
Wonderful. And Ola?
Thank you very much for such a wonderful question. Thanks God, waking up every day with the thoughts that our life is continuing, so we have feeding, electricity, internet, and our children are healthy. So that is the most important thing.
When we open up about tuberculosis, it's probably one of the most fascinating things is thinking through the discovery in terms of ancient biological history. Lorenzo, when was it first described, as well as where it's thought to have emerged?
TB is a very long-standing pandemic. It's more having an unwanted guest for the human species in history because mycobacteria have evolved together with mankind. Mycobacterial tuberculosis has been described for the first time by Robert Koch in 1882. But of course, the story begins much earlier. It is thought that mycobacteria originated more than 100 million years ago. And in terms of mycobacterial tuberculosis that we know today, the first proofs of infection in humans date to the Egyptian time. So there are findings of mummies which have signs of TB infection of the spinal bone, so what we call today pot disease, around 5,000 years ago. It's a long story. In terms of where this has all originated, it is thought to come from the region of East Africa, as for many important parts of the human development.
In today's world, who does endTB actually infect and what are the reservoirs? Is this like other infections where there are environmental reservoirs?
If you think about tuberculosis, the main mycobacterium linked to human disease, This can affect animals, so we can think about Mycobacterium bovis and cattle, but most of the reservoir is mostly humans, and transmission, as you know, is intrahuman through the exchange of droplets, so respiratory transmission. It's interesting to think that it's one microorganism which could actually be eradicated. Theoretically, it is possible. We are very, very far from that because we know from modeling studies that approximately 1/4 of the human population has encountered mycobacteria and is considered to be infected by endTB.
So, Ola, can you give us an overview of the pathophysiology? How does M. tuberculosis get in to its host? Why can't we get rid of it? What happens over time and to whom? Can you sort of do a refresher for us?
Thank you for the wonderful question. Just to follow Lorenzo, I want to say that Mycobacteria bovis is the pathogen that can get the host organism through the alimentary way of transmission, the majority of cases. But as we know well, 95% of all cases of tuberculosis are airborne way of transmission. So through the droplets of sputum, and then a person inhaled air that contained droplet nuclei with Mycobacteria tuberculosis, most of the larger droplets become locked in the upper respiratory tract, the nose and throat, and it's very difficult to develop tuberculosis in upper respiratory tract. However, infection may begin when droplets nuclei reach the alveoli, so lower respiratory tract. In the alveoli, some of the tubercular bacilli are killed, but a few multiply in the alveoli, and then they can spread through the lymph vessels to lymph nodes and bloodstream and spread throughout the body. That's why tuberculosis may develop in any piece of body, but for sure the target place is lungs. Pulmonary tuberculosis is the most common cases of disease, but we can find tuberculosis also in kidneys, in brain, in bone, except hair and nails. Mycobacteria is a specific microorganism. Within 2 to 8 weeks, the immune system usually tries to deal with infection and prevent the further spread of infection. And the immune system protects the body from developing the active disease. But TB infection means that mycobacteria are in the body, but body's immune system is keeping the bacilli suppressed and under control. Our immune system thus produces special immune cells that surround the tubercle bacilli, and cells form a shell that acts like a barrier and keep the bacilli contained. So that's why it's very difficult to fight with mycobacteria, because it's protected by our own immune system. That's why we get infected for a very long period of time, and some patients can develop active disease.
Here actually seems like a really good moment to stop and discuss terminology a little bit, because we are no longer really supposed to say latent tuberculosis, right? We are now supposed to say that a human without symptoms does have an infection, but it's simply a tuberculosis infection, whereas someone with symptoms has tuberculosis disease. Am I correct?
That is true. We have changed terminology. Right now, we say that people who have tuberculosis infection, but not TB disease, they are not contagious. They do not feel sick and couldn't spread the infection to another people. And most of these people have a normal X-ray. And it is important to remember that tuberculosis infection is not a case of active TB disease. But people with tuberculosis infection can develop tuberculosis disease later. TB disease develops when the immune system cannot keep the mycobacteria under control, and the bacilli begin to multiply rapidly, with a high risk TB disease in some groups of patients. For instance, patients who has immunosuppressed immune system, HIV-infected persons, or people who get corticosteroids treatment. So we have 23 risk group of development of active disease right now.
And as we talk about terminology, I mean, subclinical TB is not something that we deal with in a clinical space, but it seems like that's getting more attention because of how much it contributes at a population level to transmission. Any comments or thoughts on where that fits in this spectrum of TB infection and TB disease?
It goes a little bit out of my expertise. I can say that detecting subclinical disease seems to be, well, we are really bad at, and that's where we need to improve, probably to have a real breakthrough in our capacity to control pandemic. There is more and more evidence that we are not able to diagnose TB before any symptom occur. This is something that has been seen with the available tests if we go and do active case finding or mass screening campaigns. But this is not something that we can do with this mass approach. We need to be able to better identify and understand which groups we should be targeted and have better tests. But this is definitely one of the big focus of research in these last years.
When we think about the prevalence or, the epidemiology of tuberculosis, where are we seeing hotspots globally of TB, and where are we also seeing drug-resistant TB?
So today we have every year around 10 to 11 million new cases of tuberculosis in the world. This is a figure which is very high, of course, and it's unfortunately not really changing since at least a decade, and basically since the WHO has numbers which are becoming more and more reliable in terms of estimation. What is very striking is the mortality, with more than 1 million people affected by TB who die each year. This is really incredible if you think that this is such an old disease and it is today preventable, like possible to diagnose it, and also completely curable. TB is concentrated in 30 priority countries, which are defined by WHO, and this is something which is easy to find checking the WHO Global TB report every year. But if you only look at the 5 highest burden countries, India, China, Indonesia, Pakistan, and the Philippines, we have more than half of all the cases. So there are priority regions for action with the WHO. This is a little bit different if you talk about drug-resistant TB, talking about AMR, which is also a huge concern for TB since at least the 90s, with the discovery and description of the first cases of multi-drug resistance. We have around 500,000 of new cases every year with people who are infected by strains that are resistant to rifampicin, with or without the additional resistance to isoniazid, that will fulfill the definition of MDR-TB. These cases are also localized in specific hotspots. The highest rates are from Eastern Europe, Central Asia. However, if you look at the number of cases and the burden of disease, the most affected part of the world is still in Southeast Asia, just because of the total number of cases which are higher there.
So we were talking before about tuberculosis infection, which on its own is really what we used to call latent TB. And then you have tuberculosis disease. Olha, you said before that those with asymptomatic or subclinical infection are not the ones transmitting. They're not infectious because they're not symptomatic. They're not coughing. They're not really shedding. But we know from what Lorenzo said that is actually feeding the prevalence, really, because those people will live longer, they will reactivate, and they will become infectious one day. So, of course, we want to target them. Can you just do a quick review for our audience of screening for this group, this very large group of asymptomatic people who are infected? So we all, I think, know the Mantoux test, which in the States is known as the PPD, purified protein derivative, the skin test. Is that completely dead in high-income countries? And can you remind us, how does the alternative work, the interferon gamma release assay?
Screening for asymptomatic tuberculosis and tuberculosis infection is quite difficult to organize sometimes because it depends on the politics of countries and governments. And I know definitely that IgRA tests are much more effective, but they are expensive and some countries can't implement it 100% for all people who need that. That's why TST, tuberculin skin test or Mantoux skin test, is still recommended for sure as one of the tests for tuberculosis infection. This test detects immune sensitization type 4 or delayed type hypersensitivity to mycobacterial protein antigens. And this test is very good. Sometimes it's very useful for patients who were not BCG vaccinated previously. It's just a small injection intradermally, We inject 0.1 milliliter of tuberculin. In some countries, it contains 2 tuberculin units. In some countries, it's 5 tuberculin units. We had to check the test reaction between 48 to 72 hours. IgA rays are preferred method for testing for people who might be less likely to return for TST reading and interpretation. For example, homeless persons or drug users, people who have received the BCG vaccine, or people who are likely to be infected with Mycobacterium tuberculosis and are at low to intermediate risk of progression to TB disease, and people who are unlikely to be infected with Mycobacterium tuberculosis. But we have limitations. We had to have laboratory. Healthcare workers should be properly trained on how to conduct with IgA ray. And healthcare workers should confirm arrangements for testing in a qualified laboratory. Arranged for the delivery of the blood sample to ensure testing of samples with viable blood cells. It's quite difficult to organize sometimes. For instance, in Ukraine, previously, it was available just in commercial labs, but now our public health center recommends us to use it even in war zone settings. So we are trying to organize this test right now, and we see it's very good. What is the action of this test? Patient blood samples are mixed with antigens and incubated. The major antigens are found in Mycobacterium tuberculosis strains. If a person has Mycobacterium tuberculosis infection, the blood cells in the sample will recognize the antigens and release interferon gamma in response. Blood samples are also mixed with control substances, and these controls are used for comparison purpose to help verify test results and to determine a person's background level of interferon gamma.
Thank you. Yeah. In Switzerland, we don't do the skin test anymore. I think it's been several years now. The new medical students have really no experience with that. We still teach it. We teach both. They know that it exists, but it's not being used at all. A question now for Lorenzo. So I am here in Switzerland, high income country, and we abuse our diagnostic tests. And it is tempting to order an IGRA to help rule out active tuberculosis disease because a negative result is great. It lets you sort of knock tuberculosis off of a long list of differential diagnoses, no prior exposure, no current disease possible, right? When should IGRAs not be used?
To have a simple answer to this question is that IGRAs should not be used to rule out active TB disease at all. That would be the easy answer. These tests are actually just not designed for that, and they are not good enough. I think Olha has explained very well the advantages of the IGRAs over the MAN2 test, but these are really limited on being able to discriminate infection in vaccinated people. But apart from that, the performance of the test in terms of negative and positive predictive value didn't really improve. And despite a lot of efforts and also new versions of these tests are just not good enough. We cannot be reassured by a negative test. We cannot be completely reassured. It's difficult to diagnose cases. So this happens a lot in clinical care. So we are all tempted to do that. And sometimes these tests are done, but I fear they may just mislead us more than anything else. If it's positive, its value is even more limited. And in the end, it basically doesn't say much at all. So as a conclusion, I think we should mostly reserve IGRAs like we did with MAN2 for the diagnosis of TB infection and everything which is related to case finding, screening of contacts, and not use it in a routine for the diagnosis of disease.
Yeah, thanks. I have a bit of a cautionary tale because I was just on service and we had a young man who geographically came from a region of very high tuberculosis prevalence, and he was presenting with fevers of unknown origin. He didn't cough a lot, so that threw some people off. But above all, he had a negative IGRA test a year before that was well documented. First thing that was done when he came in was an IGRA test, negative. So that really lowered the index of suspicion to many doctors who saw this patient before we did, and tuberculosis was not high on the list. We really insisted on a lavage because we didn't understand what he had, and sure enough, PCR positive right away for M tuberculosis on the first isolates. So I think you're absolutely right. The real answer is just don't do it. If you're dealing with active disease, it's a screening test. It's not there for active disease.
I agree. And I hear my attendings teach the fellows all the time about negative IGRAs don't help you when you're trying to rule out disease, right? You have to compartmentalize those types of tests differently. What are the other ways that tuberculosis can present when we're thinking about extrapulmonary disease?
95% of all cases of tuberculosis, it's an airborne way of transmission, it's pulmonary tuberculosis. The most common chest symptoms are cough, sputum, breathlessness, dyspnea, chest pain, and pulmonary bleeding. These symptoms typically accompanied with intoxication symptoms. The most common of them are subfebrile fever, 37.5.2, night sweats, fatigue, weight loss, absence of appetite. So these intoxication symptoms may mask many different diseases, for instance, oncological diseases. So if we combine two groups of symptoms, chest symptoms and intoxication symptoms, we can think about tuberculosis, pulmonary tuberculosis. But as we already said, we have 5% of another localizations of tuberculosis, non-pulmonary. And the most dangerous, it's tuberculosis, meningitis, and encephalitis. If we see a person with a unknown reason of intoxication symptoms and with the symptoms of meningitis, we have to think about HIV infection and about tuberculosis, especially in countries with high incidence rate of tuberculosis, because we know that 30% of HIV infected persons are infected with mycobacteria, and in contrary, 30% of tuberculosis patients may be infected with HIV. So it's a very dangerous combination, and tuberculosis meningitis is very dangerous and patient may die very fast. We have also another localizations of tuberculosis, for instance, tuberculosis joints and bones, tuberculosis of kidney and another organs. So symptoms depends on the localization.
Thank you, Olha. Your point that we can see it in all different sites is quite important. Even if the portion of extrapulmonary TB is a small portion, there's enough prevalence of the disease in the world, you're going to see these. Although it sounds rare, I mean, TB lymphadenitis and other extrapulmonary disease is something that will be encountered at some point.
It was very nice to hear all the possible clinical presentations of TB. It is important to remind that the classic presentation of TB is probably very easy to diagnose, but most of the times this is a disease which is very difficult to differentiate from others. So it's really complicated. And I think the key is having a high level of suspicion and thinking about TB, in particular, looking at the epidemiology in your center from the provenance of the patient. And the proportion of patients who have extrapulmonary TB is very different actually in different parts of the world. This is not completely explained. For example, in Ukraine or in Europe, there is a very high prevalence of pulmonary TB, striking majority. But in other parts of the world, like the Indian subcontinent, there is actually a very high proportion of extrapulmonary TB. As you were saying, lymphadenitis, for example, or TB pleuritis are also very common.
Yeah, and there's variability across the age spectrum too. When you think about contacts and pediatric TB versus adults, it's such a complicated pathogen and it can cause so many different presentations. The easy part is when you have classical pulmonary TB, but when it deviates from that, it's really important to make sure you're involving not just infectious disease specialists, but also folks that might specialize in management of tuberculosis. Lorenzo, what is the diagnostic workup for these patients with symptomatic TB disease? And unfortunately, there's a lot of waiting involved. What are you doing in the interim as you're waiting for some of this workup to come back?
The classic workup for diagnosing TB, which is still very much in use, would be collecting a sample. Usually we'll start with a sputum sample. If the patient can produce sputum, sometimes you have to be more invasive, do a lavage, a bronchoscopy, and it could go all the way to biopsy. Have these multiple samples collected and, the best possible samples. So the sputum has to be collected in the correct way. The patient has been instructed. It's super important to do it for diagnosis because in particular, if then at one moment we will start an empirical treatment, we will regret if we didn't have these good samples examined. We will collect multiple samples. So having at least 2 or 3 is seen as the best practice still today. And then we will send them to the microbiology lab, which has to be specialized and perform microscopy, looking at the smear for mycobacteria. And then they will put the sample in culture, which we know it takes a long time. Of course, if the smear is positive, that gives you a big confirmation towards the diagnosis of TB. But in many cases, you will just have to wait for the culture. And then finally, we also have new tests being developed in the last decades, which is fortunate. So rapid molecular testing have become the standard of care in many, many settings. These are really well spread out across the world. In particular, rapid molecular tests that allow the detection and genomic diagnosis of tuberculosis, so the infection by disease by Mycobacterium tuberculosis complex, and can also give at the same time an answer on the presence of the most common mutations which are associated with resistance to rifampicin, for example. There are other tests which are equally easy to do and rapid that can even give you the answer on the resistance to isoniazid, which is the other key drug, and fluoroquinolones, which are the key drugs among the second line compounds. It's actually not a luxury. I think it's just the standard of care today. It's really important that each patient gets these rapid molecular tests done to detect resistance to rifampicin and isoniazid. I think this is really the best care that we can offer. That the regimen that we use is supported by evidence and will work well. It's still not done everywhere, and there are a lot of constraints in terms of access and cost. Coming to the second part of Nav's question, why we wait for all of this? If you have a rapid molecular test, this will come in a couple of days, and that is great. It doesn't happen all of the time. Usually the approach would be to assess the risk of the patient being contagious. This is looking at the microscopy results, also the clinical presentation, the radiological pattern. Of course, we know that the contagious forms are the pulmonary ones. And then based on all these elements, decide if the patient has to be isolated, which will be in most cases if there is a high degree of suspicion, while waiting for the best approach. Once you have collected all the good specimens, you have done everything that you can. If the suspicion level is high, it is also a good approach to start an empiric regimen, even though it's something we always get discouraged to do, but that is something that happens in some cases because you cannot wait for the culture results before starting treatment if you have a high degree of suspicion.
That's always a tricky question that I see our fellows teeter on if they should start empiric therapy. And it never seems like there's a clear answer one way or the other, but all those factors might push you to watch and wait versus you can't watch and wait. They're too sick and your index of suspicion is too high that you should be starting them on anti-TB therapy right away.
This is particularly true actually for special groups of patients where the diagnosis is even more difficult, such as HIV positive patients. Olha, as mentioned, but also children, which is really a neglected group of patients with TB, and where it's very difficult to obtain a good sputum sample. Now it's actually the real push by NGOs like MSF and other big stakeholders like the WHO to use clinical algorithms with radiological tests. If there is a high level of suspicion based on a clinic and radiological presentation, even in the absence of microbiological confirmation, do not wait and treat, also because there is a high mortality in small kids affected by TB.
And even if you think about extrapulmonary disease, like Olha mentioned, TB meningitis, the diagnostic yield is quite poor and the mortality is extremely high. That's just an example of TB disease that cannot wait. And even with effective therapy, the mortality rates are still high. If you add on a long lag time to starting effective therapy, then you worry about even more worse outcomes at that point.
Yeah, and it's interesting that now we accept treating people without any microbiologic confirmation. It does make sense. I think we all know pretty well now how to deal with these therapies. We understand what the side effects could be. We can handle it. And ultimately, when you don't have a microbiologic diagnosis, the treatment itself can be kind of a diagnostic maneuver. Right? You see if they're going to respond. If they are, that's a hint that you're on the right track. So speaking of treatment for active disease, traditionally, the regimen of RIPE has held sway for many years. After this combination was tried and tested in early randomized trials decades ago, RIPE, as a reminder, is made up of a quadrotherapy with rifampicin, which we call rifampicin on this side of the Atlantic. I think it's rifampin, as I recall, in the States. So we've got rifampicin and isoniazid. That's the R and the I of RIPE. Those you get for a full 6 months. And then the P and the E are pyrazinamide and ethambutol. The pyrazinamide and the ethambutol you're giving only in the first 2 months, hopefully, if the organism turns out to be sensitive. So are things changing now, Lorenzo? Is this regimen still recommended by most expert groups, or are there alternatives that require maybe less time, fewer medicines? Can you give us a little update on what's happening?
I really like the RIPE acronym. In the field, we tend to use much less sexy acronyms like HRZE. So I really appreciate that. Thanks. Unfortunately, I think it's still RIPE time in most regions of the world as the standard 6-month regimen with a few, of course, adaptation for specific cases. But as a standard building block is still by far the most used regimen. However, there has been a very big breakthrough 3 years ago with a phase 3 trial on drug-susceptible TB showing for the first time the non-inferiority of a shorter regimen, a 4-month regimen, which has a very, very similar performance to the 6-month regimen for all adult patients with rifampicin-susceptible tuberculosis. This regimen replaces rifampicin with rifapentin, which is a long-acting rifamycin, which has overall similar properties apart from the longer half-life. It's used in the regimen at high dose. This is an important point. And the other important change is the use of a fluoroquinolone, moxifloxacin, instead of ethambutol, one of the weakest companion drugs, which are there mostly to protect the other drugs. Study 31, a landmark study because so many trials in the last 20 years actually failed with a similar objective to reducing treatment duration from 6 to 4 months. They tried with similar approaches, but in particular with the use of fluoroquinolones. But what is new, as I mentioned, is also the use of high-dose rifamycin. This 4-month regimen is a little bit different also in that after the initiation phase with the 4 drugs, the continuation phase is continued with 3 drugs. So in addition to rifapentin high dose and isoniazid, there is also moxifloxacin given also for the continuation phase. So this is really great, but in practice, it has not been really rolled out in many countries, and there are actually a lot of hurdles. I can only say that there is a problem of access in terms of actually having the drug registered. So rifapentin is not registered with the EMA, is not available in most countries in Europe, and it's likely not going to be, despite a lot of push from different organizations. And this is not the only access problem in the European Union, in Europe. Far from that, but it's maybe one of the most striking. In addition to that, there is the cost. We have a problem of pill burden because this new regimen doesn't have fixed dose combination pills that allow to reduce the total number of pills. So the number of pills with this new regimen is much bigger than the one of the standard regimen. There are a few questions on how much we want to promote using fluoroquinolones for all cases everywhere with all the concerns that we have about AMR. At the same time, not to reduce the importance of this new breakthrough, reducing from 6 to 4 months could be really, really important, in particular in some populations. So I think it's something that we would really like to be able to use in Europe.
We have this regimen. I think we are very much satisfied with that, but we have some limitations because we have pattern of resistance. For instance, patient has Mycobacterial tuberculosis susceptible to rifampicin but resistant to fluoroquinolone. That's why this regime is not useful. And before the prescription, we have to check the resistance. Luckily, we have GeneXpert cartridges, special cartridges which identified resistance to second-line drugs. Cartridges XDR. They are available, and this is mandatory for us to have this test done before the prescription of this new regime, because it's very important to be sure that Mycobacteria is not resistant to fluoroquinolones. So this regime is useful for not severe cases of pulmonary tuberculosis, and we have very good results. But another limitation is that the dosage of rifapentin is very high, 1,200 milligrams. It's 8 pills, and sometimes patients they don't want to swallow all these pills. So with that, we need to explain patient how to deal with that.
The worry about the fluoroquinolones I mean, it's interesting. We don't like to use fluoroquinolones in the hospital because patients exchange plasmids and it really can change the entire microbiota of the hospital, right? But when patients are at home and not in close quarters, in theory, right, with other people whose natural flora might be quite perturbed, also getting antibiotics, etc., then I think it's really less of a risk, less of an ecologic hit, let's say, for AMR development.
It's a great point. I think in the TB world specifically, we have a lot of problems with acquired and growing drug resistance to every new drug which is developed, which it's true for every bacteria, of course. But it has been really striking. And I think that's a little bit the fear that if we use fluoroquinolones a lot, then they may become more and more prevalent among even new cases of tuberculosis.
Yeah, it's that topoisomerase. It's a point mutation, right? At least for regular gram-negative bacteria, let's say like Klebsiella, E. coli, it's not very hard for them to become resistant to quinolones. So let's talk about happier things though, Lorenzo. Please tell us about your program with Doctors Without Borders. Tell us about the endTB project.
The endTB project is a large program that has started more than 10 years ago, funded by UNITED and promoted by 3 NGOs, which is quite unusual for a research project like this. These NGOs being Médecins Sans Frontières, MSF, based in France, and then we had Partners in Health in Boston, in the US, and Interactive Research and Development, or IRD, based between Pakistan and Dubai. And these 3 NGOs got together with the goal of really improving the management of drug-resistant TB with the availability of new drugs which were developed, the first new drugs to be developed for the treatment of drug-resistant TB specifically after more than 50 years, which are bedaquiline and Navaneeth, together with other drugs which were repurposed for the treatment of TB and extremely resistant forms of TB, such as linezolid and an anti-leprosy drug like clofazimine. So having this window of opportunity of having multiple drugs, which were developed in part by private companies with a lot of public funding, where the development actually stopped at phase 2 because the company felt that phase 2 was actually enough to get into the market because of the desperate situation of the RTB treatment. So phase 3 were not really needed. But of course, you need phase 3 trial to have good evidence to find the combinations of these drugs and to finally get to shorter regimens. Standard of care for drug-resistant TB for many years has been a very long regimen of almost 2 years with a lot of drugs, between 4 and 6 drugs, with a lot of side effects, the use of injectable agents every day for months. So we needed to find a good combination to shorten the treatment and find better tolerated options. And that was the goal of the project. And I would say the main parts of the projects were 2 phase 3 clinical trials called endTB and endTBQ, looking at shorter regimens for fluoroquinolone susceptible and rifampicin resistant TB. And that was endTB. endTBQ looked at fluoroquinolone resistant, or what we call now pre-XDR TB, and testing different regimens of 6 to 9 months, which had different combination of these new and repurposed drugs, and also fluoroquinolones and parazinamide for endTB. To make the long story short, after many years of study, we could identify 4 new regimens that were non-inferior or even in some cases superior to the control, 3 for fluoroquinolone susceptible tuberculosis and 1 for fluoroquinolone resistant TB, which are now being recommended by the WHO. So they are among the options for the standard of care for rifampicin resistant TB, for the endTB trial, for the endTBQ trial in the very evidence-free space of pre-XDR TB. endTBQ is just been released in terms of public presentation, and it's the first and only phase 3 trial in this population. So we hope that this evidence will be reviewed soon by the WHO and will lead to recommendations that can be implemented worldwide.
That sounds like such a success story that you were able to define and safely test these regimens and come out with good news ultimately.
Yes, it's also a story of NGOs and in particular MSF, which was the sponsor of the 2 trials, having to go a little bit beyond what their comfort zones. So we had a lot of academic partners, and I think that can be a model for other kind of research. But on the other side, it's also a failure of the standard system of development, which basically didn't go all the way. Also because the companies were not really encouraged to go all the way in the development. Once again, I would like to highlight that there is a lot of public funding and a lot of help and shortcuts that are provided to companies that work in this kind of orphan diseases, such as drug-resistant TB. But there is not much in terms of commitment that the companies have to undertake. I think there is some space for an improvement also in the overall regulatory framework to make sure that the next coming new drugs, there are a lot, are actually more quickly included in new regimens, and so they can have an impact, a fast impact on the life of TB patients.
I think it's an important model that you're talking about. First of all, you have 3 NGOs that were able to cooperate with one another. You have a lot of players, like you say, a lot of academic players as well. You have incredible collaboration going on for what shouldn't be an orphan disease, but ultimately for the industry-based world, it is an orphan disease. These things need to be highlighted more.
Angela, I'd second that completely. It's pretty remarkable to think about the biggest infectious killer having also a free market failure in terms of the development of therapeutics and the alternative pathway that had to emerge to meet the demand, right? Which is NGOs and not the typical highly funded pathways that help attack these diseases that affect everybody globally. It's really remarkable to see this work done and have these extremely positive results. It's not just one regimen.
It was the philosophy of the project to have multiple options and not just one winner regimen. It was really the trial design for endTB. We had 5 different experimental arms and, of course, the internal control. And it was not a classic multi-arm, multi-stage design, which has been used a little bit in TB research. We really designed it to find 2 to 3 different regimens that could give alternatives, because we know in the end the choice should be there for clinicians and patients because of intolerances, drug resistance, side effects, etc. And this brings quite a few options for the RTB treatment because there have been other trials ongoing. This is great. It's a very good thing that we have to choose now between different regimens. Countries and stakeholders should get used to that.
Olha, clinically, I don't think anyone out of the 4 of us deals with drug resistance probably more than you might. Especially in your setting in Ukraine, what is a typical pattern that you're seeing of drug resistance, and how are you treating these patients with rifampicin resistance? I'll come over to your side of the pond, Angela. Rifampicin resistance, INH resistance. How are you dealing with these multi-drug resistant strains?
Well, with the beginning of war, we have a changing situation with the epidemiological patterns of resistance because we have a lot of internal displaced persons. For instance, our citizens from our region, from Kharkiv, went to west regions of Ukraine, and western citizens came to us because we are very close to military conflict, and we have a lot of people who are in our settings, and that's why we have totally different patterns. Before the starting of treatment, we have to check the resistance for sure. And as I said previously, we are very lucky to have XDR machine for GeneXpert XDR cartridges, and we have the results till the end of the working day. And we see that 30% of all cases of resistance are patterns of pre-XDR. So we have combination of resistance to isoniazid, rifampicin, and fluoroquinolones, at least 3 drugs. But we have also different patterns. For instance, resistance to isoniazid and ethionamide without resistance to rifampicin. So this is a quite challenging process to prescribe the treatment because we have to choose what combination will be the better for patient. Again, we are lucky because we have BPAL regime. BPAL is a new regimen for treatment of multiple drug-resistant tuberculosis, contained with at least 3 drugs, bedaquiline, linezolid, and pretomanid, and with combination of moxifloxacin. So we have medications for that, and we see that these regimes are very good, but again, it has limitation because sometimes we have combination of resistance to moxifloxacin. So we have choose which regime is better for patients, and sometimes we have to stop BPAL and continue with another schemes to include, for instance, another antimicrobacterial drugs from group B and group C classification. Another bad problem is that we have cases of resistance to bedaquiline. and to linezolid. So we have cases of XDR tuberculosis, extensively drug-resistant cases, and we have to change the schemes of treatment, depends on the resistance. And sometimes it's quite difficult because we have totally resistant strains. Since 2017, we had about 30 cases of such patients, and unfortunately, the majority of them already died. And some of them we don't know because of the beginning of war. Some of our patients were lost to follow-up because of the military conflict. Some went to Russia, some went to European countries or to another piece of Ukraine, so we don't know the destiny at the end.
Thank you, Olha. I think we could do a whole other episode on conflict and disease resistance, prevalence of disease. It's kind of shocking.
And I want to add one comment. Since the last several months, we have the DST for Narayanan. And we hope that for now we have no cases of resistance to Narayanan. So it's a new drug for treatment of multiple drug-resistant tuberculosis. And hopefully the resistance is developing very slow. We don't know.
Olha, indeed, you have been in a war zone for nearly 2 years now, and you are managing to continue to conduct research, if I understand correctly. What is the war doing to tuberculosis transmission and control, and what is it doing to your activities, your ability to do research? Can you share some of what you're experiencing? Can you tell us a little bit about your research?
Thank you for the question. I think that the beginning of war changed us a lot. Do you remember the movie from the 19th? Men waking up every day at the same conditions.
Groundhog Day?
Yeah, and I think that the majority of people, we are living in the same feeling. I don't know how to explain. Now we have about 1 million inhabitants, even in Kharkiv, and 25 kilometers from the war zone. And I don't know how it works, but our tuberculosis is under control because we have enthusiastic people who work with us. We have a lack of healthcare workers, but people who are still here, they are totally enthusiastic, and we try to do something. How to explain? We are trying to manage with all these things with very new ideas, because at the beginning of war we even have no food. But now we have everything because we have volunteering people who move from one region to another region. We have a special car with a portable X-ray viewer and with a nurse and radiology technician. This car with 2 healthcare workers moved from one village to another village to check the citizens of this village near a war zone, and we try to collect samples of sputum, to collect blood, and to do the X-rays. I think it's very good because people who are living in these conditions, they have no possibilities for healthcare at all. And regarding our research, just before war, we had the clinical trial approved with FIND. This organization from Switzerland. And just before war, 22nd of February 2022, we have approved the clinical trial. And since the beginning of war, we didn't know what to do. Postponed this trial or stop it totally, we didn't know. But at the beginning of June 2022, we decided to continue. The management of FIND decided that it's risky, but we have to start because our setting is very high prevalent with tuberculosis. We had a lot of challenges and issues with the logistics, border control, customs service, but we tried to find how to deal with that. We have a lot of brilliant experience, how to transport the equipment, the cartridges, test tubes or something, because we have lack of that at the beginning of war, and we find the ways. Volunteers help us to organize all that, and we were able to enroll patients for these studies. So I'm very proud of that. I think this experience helped us to understand that doing research is because of enthusiastic people. Because we want to fight tuberculosis, we want to stop a pandemic spread. And that tuberculosis and war go hand in hand. So I think it's the best time to do something new. I'm interested in the epidemiology of strains of Mycobacteria tuberculosis, and I did this sampling collection since 2016, and we did next generation sequencing and whole genome sequencing, and found that we have the majority of strains from the Beijing lineage. It was 5-6 years ago, and I'm sure that for now we have something changed because we have different patterns of resistance. So I strongly believe that we need to do the mapping of strains of mycobacteria in Ukraine because it's interesting and should be studied.
Thank you, Olha. Your insight is really incredible. I mean, and the work that you're doing before the war and even now during the war is incredibly admirable. I think we have a lot that we can learn from the work that you do and the way that you're able to sustain it. Tuberculosis is incredibly complex. Public health, epidemiology, and also the social aspects to it and the population level health. So thank you both. As we're coming to a close, there's so many things that we didn't even get to talk about. But what we can do to end, Olha, Lorenzo, is if you can give your key messages, what you want our listeners to be able to take away.
Even in this very conservative and slowly progressing field of TB, which is a little bit like the mycobacteria, it's really slow and resistant to change. We are looking at new approaches to the management, in particular the treatment of TB. This opens the door to having a more personalized approach, and in approaches even of stratified medicine are being more and more advocated. So having different options, knowing different strata of risk that can lead to different treatment duration and treatment regimens. I think this is something within reach and more accepted in the field. So that is really exciting for the next years. And then on the less bright side, all this innovation is completely useless if there is no access on the field. And this is a big problem. We just quickly discussed about cost issues, registration issues. We are talking about lack of funding for research, lack of political commitment to address TB with ambitious goals. The main message would be that we know this disease is treatable. We have the tools now to do much better than what we do, and there are no excuses not to do it everywhere.
Thank you so much, Lorenzo. These are important messages that maybe we don't want to hear, but we do need to hear. Olha.
I think that the center of all our things that we are doing should be patient, because tuberculosis is a very stigmatized disease and patient doesn't want to be diagnosed with tuberculosis. And we have to do something to advocate this. Because as Lorenzo said, and as we all understand, tuberculosis is preventable and treatable disease. But we have to help our patient and society to be together. We see in our settings, for instance, tuberculosis is very stigmatized even in families. We see that families divorced because of disease of husband or wife. It's quite difficult to explain the society that tuberculosis patients, since the beginning of treatment, after 2 weeks, patient stopped being dangerous. And that is the most important thing, that we have to more advocate this. And for sure, personalized treatment, as Lorenzo said many times, that we have to maybe change the dosage, change the schemes of treatment. Special schemes should be prescribed, depends on the resistance. And for sure, if we have access to drugs, we have to make access to drug susceptibility testing.
Thank you so much for these important last messages. And thank you so much to our guests, Lorenzo Guglielmetti of Doctors Without Borders and Olha Konstantynovska of Kharkiv National University. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Narayanan and Angela Huttner, editors at CMI Comms, ESCMID's open access journal. It was edited by Dr. Katie Hostetler and peer-reviewed by Dr. Maria Ana Flores of Lisbon, Portugal. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks. Any literature we've discussed today can be found in the show notes. You can subscribe to Communicable on Spotify, Apple, wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.